Hi everyone, good evening my dear students. I'll just open up the session on my phone as well. Yes, here it is. Just a second guys, I'll just open up the session on my phone also. Yes. So good evening everyone, good evening everyone, good evening everyone. Let's see how many people have joined till now. Just a second guys. Just a second. Here it is. Link. Yes. Okay. All right. So again, good evening, Srishti, Abhinav, Rafnan, Harshita, Khushi, Khushbu, Pratiksha, Shweta. Good evening, everyone. Let's wait for a minute or so for others to join in because people are still joining in. Kangan, Amrita, Varshini. Good evening, everyone. Salva, Harshita, Namrita, Kishore. Good evening, everyone. Am I audible? Is my screen visible to all of you? Please give me a heads up so that we can start without wasting any time. Okay. So I know all of you are dead serious about the upcoming exam. So you have got NEET exam scheduled on 2nd of May, which is only 36 days from now. And immediately after that, just 2 weeks after that, you have got INI CET coming up. So I know all of you have got lots and lots of doubts. I have been looking at the Telegram group. I have been solving the doubts also on a. I would not be very. I will be. I'll not be. I'll be honest with myself. Actually, I was not able to solve them very frequently, very consistently. But yes, whenever I find time for my practice, from my busy schedule, from my family, I do. I do find time to solve all the questions. Other than that, this session is specifically for those students who are actually looking forward to securing ranks in the exams, who are dead serious about their goals, who have got questions in their minds which require immediate assistance. So I'm here for you. I have got certain questions. I've got certain questions, a list of questions which I have prepared accordingly for. Why is this not functioning? One second, it hanged actually. One second, it's not working there. Yeah, now. Particularly for mixed dentition analysis are important. Then this is an example of, this is a slide of Bolton's analysis. So two or three things have to be remembered in this. So Vine Bolton, am I audible now, guys? Guys, am I audible? Am I audible now? I have seen many, uh, almost everybody is saying not audible, not audible, not audible. Am I audible now? Am I audible now? Am I audible now, guys? Please let me know in the chat box. Am I audible? Okay. Okay, fine. Kishore is asking me to repeat again. There is no sound. We have Ashley's analysis that is used for discrepancy between the apical bases of the jaws, not the teeth, like that. So the names and the corresponding importance, clinical importance of those analysis is what is required for you to understand. If we talk about Moyer's analysis, Johnson's analysis, Tanaka Johnson analysis, Hakuba's analysis, right? So you have to exactly remember, you have to exactly know what that analysis is and for what purpose it is used. Okay, then questions are numerical based on model analysis. You will be asked questions on maybe Tanaka Johnson analysis, on Bolton's discrepancy. So for that I have mentioned this slide here. Again, no sound, not audible. I would request the DBMCI team to please look into it. Many people are saying there's no sound again and again. It's interrupting actually. Please look into it, please. Right? So Bolton's analysis, we have to remember the overall ratio is 91.3 percentage. That's the ratio between the overall mesorectal width of the maxillary teeth, maxillary 12 upon the mandibular 12 into 100. When this ratio is less than 91.3%, it means the maxillary tooth material is in excess, which can be calculated by this formula written on the screen. And when it is more than 91.3%, it means that the mandibular tooth material is in excess, again, which can be calculated by the formula given on the screen. So the thing you should remember is the clinical importance of these two values, 91.3 above, 91.3% below. What does it imply clinically and how to go about answering the questions. Yes, Aman is saying yes, this is important. This value 91.3% is important. Similarly, we have anterior ratio, which is 77.2%. So instead of the 12 teeth, we are looking at the sum of mandibular 6 upon the sum of maxillary 6 into 100, again expressed as a percentage value. If it is less than 77.2%, it indicates maxillary tooth material excess. If it is more, it indicates mandibular tooth material, anterior tooth material excess particularly. So yes, this is important. Few people are asking me. Yes, it is important. You have to remember these values, these percentage ratios. This is important. Okay. Mixed dentition analysis. I told you we have Moyers, we have Tanaka Johnson, then we have Staley and Kerber's analysis. I don't think you'll be asked any numerical question out of these analysis. You have to remember the names and the purpose for which they are used and how they are done. We have talked about that in the live and recorded lectures earlier. Okay, so only that much is important from my point of view. The next question is timing of serial extraction. Is it in early or late mixed dentition period? So serial extraction is particularly done in early mixed dentition stage. It is not done in late mixed dentition stage, although it comes under interceptive orthodontic treatment. This is a part of interceptive orthodontic treatment, but it is done in early mixed dentition stage. Why? Because serial extraction involves removal of CD4 or D4C. These are the two methods. These are the two formulas for serial extraction. So you have to extract the premolars. The fourth number tooth, premolar, is extracted very early in the developmental stage, and that is corresponding with the early mixed dentition stage only. So the timing of serial extraction is in early mixed dentition stage. It is not in late mixed dentition stage. Okay, guys. Next, preparation of orthodontic materials. Some of you have asked me how to prepare the chapter of orthodontic materials, right? Can you please explain the first 2 points? Not audible in the starting. Which 2 points, guy? Which 2 points? Okay. How to remember model analysis and question numerical based on model. So I was saying you don't have to remember each and every model analysis, guys. All you have to do is know the exact name of the model analysis, and you have to understand the purpose for which that analysis is undertaken, whether it is done in mixed dentition or permanent dentition. Even in permanent dentition, it is used for calculation of the teeth only, the dentoalveolar discrepancy or the apical base discrepancy, and you have to make the inference according to that. All right. And questions in numerical based on model analysis. Last year we had a question on Tanaka Johnston. So we have talked about the formula to calculate the exact value also in the live and recorded lectures. The formula is there in the lectures also. Other than that, I don't think you will be asked to particularly calculate any discrepancy mathematically. I don't think so. It will be asked in the exams. Please give overview of Sassoni and Ricketts analysis. I'm going to come to the cephalometric analysis also, but these two analyses are not there in your syllabus. Sassoni and Ricketts analysis are not there in your syllabus, so I'm going to skip that. It is a very, very complicated analysis, so don't confuse yourself. Falguni Khandelwal, please don't confuse yourself. Just please stick to the questions. Please stick to the syllabus which is outlined by the Dental Council of India. Now it is NDC, National Dental Commission of UG curriculum. Okay, so these Ricketts and Sassoni analysis, let's leave that for the PG syllabus, PG course. Next is preparation of orthodontic materials. Now, orthodontic materials is a very, very important chapter, guys. Very, very important chapter, guys. Moyer's classification of class 2 malocclusion. It is there in the live and recorded lecture. Srijan, you know it's not possible for me to explain the theoretical concepts here. I have limited time actually, so I will suggest you to go back to the live and recorded lectures. You will understand the concept yourself. Harshita is asking me for image-based question how to differentiate between FR1 and FR2. Okay, so FR1 basically it's of three types: FR1A, FR1B, FR1C, and FR2 is particularly for class 2 correction. That is even class 2 division 1 malocclusion particularly. So very slight differences, and I don't think it will be asked in the exam. So you just have to remember what is Frankel about, what is the role of Frankel plans, what is the principle of action of Frankel plans, force application, force elimination. Only that is important. That is important for you. Then Frankel also is given in early dentition. Yes, it is given in early dentition stage. Yes. How to differentiate between herbs in powers? It's not power stroke, it is power scope. Again, I have the pictures in the recorded lectures. You have to go to the chapter mild functional appliances. It's there in that. Please go and look into that chapter. His thumb sucking is normal up to 1.5 years. Thumb sucking is normal up to 1.5 years. Okay. So as I was saying, this chapter, orthodontic biomaterials, is very, 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 very important. It's very important. I have seen n number of questions being asked out of this question, this chapter. It is important, guys. Don't make this mistake of leaving this chapter untouched. You will regret it later. Each and every appliance, each and every material used in orthodontics is important from MCQ point of view. I've seen exam setters. It's one of the favorite chapters of the exam setters. It's one of the favorite chapters of the exam setters. So please, I'm repeating myself, don't make a mistake of omitting this particular chapter. You will regret it later. Okay. Fitted label bow, is it 21 or 22 gauge stainless steel wire? So 21 gauge wire is 0.8 mm stainless steel. 22 gauge is 0.7 mm stainless steel. Yes or no? So fitted label bow is made out of 22 gauge stainless steel wire. Important topics in this chapter. So this is the comparison chart of orthodontic materials. Orthodontic arch wires particularly made of different materials. So I'm going to enumerate this. For stainless steel, 3-4 properties have to be remembered. It is the stiffest wire, it has got highest formability, and it has got the lowest friction. Okay. Then comes nickel titanium. Nickel titanium has got the lowest stiffness, highest flexibility, lowest formability, and it cannot be soldered or joined. That's why it is used in the early part of the treatment. That's why it is used in the initial labeling and alignment phase of the orthodontic treatment. It employs two properties, shape memory effect and superelasticity. We'll discuss about that elsewhere. It's a very complicated and very extensive topic of discussion. So just remember, it is used in the early phases of the treatment. Then we have beta titanium. Beta titanium, it is particularly used for forming loops in frictionless mechanics for retraction purposes of the anterior teeth, right? So beta titanium has good formability, but that formability is slightly lesser than as compared to the stainless steel wire. It has got very high friction. The more the content of titanium in the arch wire, the more the friction is. There's direct proportionality between the two. Okay? And cobalt chromium wire, that is called alloy wire. That's an alloy of cobalt and chromium. That's called alloy. So for cobalt chromium wire particularly, I've seen this question being asked multiple times in Telegram group. Actually, there was a confusion that although the formability is the highest for stainless steel wire, but still the maximum number of bends which a wire can withstand before fracturing is cobalt chromium wire. So this line is written in one of the boxes given in the standard textbook of dental materials written by Phillips, Anusabis Phillips. Okay, so this is an important comparative table. You have to remember the properties of each wire by heart. That is important, guys. Please don't make this mistake of omitting this also. I have certain questions. History of activator is important. Difference between pendulum and T-Rex appliance, very difficult to understand. Highest formability, I just said highest formability is of stainless steel wire. Formability is higher for stainless steel. Yes, Arinbhai is saying that alloy wire can undergo a maximum number of 8 bends. Okay. So activator is important. History of activator is important. Just a single line is important, that the appliance was mainly made by Viggo Anderson, and he actually discovered the property of malfunction appliances serendipitously. It was an accidental discovery. He treated his daughter before she went to her grandmother's place during her summer break in Norway. Norway is a Scandinavian country in Northern Europe, right? So this appliance was developed in Norway. So that's why it's also called as Norwegian appliance. So what he found out, that after she came back from the summer break from her grandmother's place, Viggo Anderson found that the mandible has grown, and coincidentally the girl, his daughter, was in the teenage period. She was within the circumpubertal period. So he researched even further along with Karl Hoppel. He was a German philosopher. He belonged to Germany and Anderson belonged to Norway. So these two people collaborated together. They researched the research backwards, at what led to the development of the mandible during that time. And then they made the philosophy behind activator plans. Okay, so that's all that is important. Difference between pendulum and T-Rex. Again, I have included the figures in the notes and in the recorded lectures. I will recommend you to go and read those parts of the chapters accordingly. Sounds affected in classroom allocution. Again, that's available in the notes in the chapter on functional development. I have created a table for you. I have taken up that table from one of the standard textbooks of orthodontics. So you have the sounds and their variation in that table in that chapter. Okay, I'm going to come to column angle, Srishank. Just wait a minute. I'm going to come to that chapter. Other things which are important in this particular chapter is this formula. The force given by a wire is directly proportional to the fourth power of the diameter of the wire and inversely proportional to the cube of the length of the wire. Okay, so this is important. What more is important is this formula again. If the diameter of the wire is doubled, if the diameter of the arch wire is doubled, what effect does it have on the strength? The strength increases by 8 times. The stiffness increases by 16 times. And the range of the wire reduces by half. The range of the wire reduces by half. Okay? So, doubling the diameter of the cantilever beam makes it 8 times as strong and 16 times as stiff and reduces the range by half. So, this is an important, I would say it's a $1 million question. Application based question. If you are able to remember this formula, I'm sure you will be able to solve each and every question in relation to this particular formula. Okay. One more formula you need to remember. If the length of the wire is doubled, what will happen? Tooth. By how much? So these two are the formulas for them. First formula and the second formula. You have to remember these formulas by heart, guys. Okay. Guys, am I audible again? The audio is gone. Oh, why so much of technical problem this time? Again, the audio is gone. Again, it's not audible. Please look into it, guys. Next is growth and development, high yield areas and concepts, theories of growth in brief, and ossification centers in the maxilla. Is it 2 or 3? That was the series of questions which I was asked about. So in growth and development, again, it's a very, very important topic. It's a very important topic from orthodontic perspective. Many MCQs are being asked in this question, in this topic. बार बार ऑडियो जा रहा है, बार बार बच्चों के क्वेश्चंस आ रहे हैं इसके अंदर. Right? So we have growth and development, high yield areas. I'm going to explain that. We have got cephalocaudal gradient of growth. We have Scammonn's growth curve. Then we have primary, secondary displacement of the bones. We have cortical drift, concepts behind cortical drift. We have concept behind bone remodeling. Okay, so all these concepts are very important. Okay, theories of growth in brief. Okay, I'm going to explain that. Ossification centers in the maxilla, is it 2 or 3? It is actually 2. You know, maxilla is made up of 2 bones, one on the right side, one on the left side. So each half of the bone has one primary center of ossification. So that makes a total of 2 centers of ossification in the maxilla. The entire maxilla particularly. One for each half. One ossification center for each half. So that makes a total of 2 ossification centers in the maxilla. Okay, guys? Column angle is angle between the long axis of the root and long axis of the crown of the tooth. Absolutely correct. In quad helix appliance, when anterior contraction is done, does expansion occur in the canine premolar region? It occurs in the molar region, basically. If the anterior bridge is contracted, the expansion occurs in the molar region. So we have to do that particularly for correction of posterior crossbite. Beta Nidhi, Moyer's classification, I told you, you can read it in the notes and recorded lectures. It's a very exhaustive topic. I do not have a slide here right now. So you can go back to the notes, refer to that chapter. The chapter is classification of malocclusion. You can read about Moyer's classification in that chapter. Okay. Falguni Khandelwal, please explain about mandibular rotation, external or internal rotation. Again, this is a very, actually this topic has to be crammed up. There is nothing much to understand in that. Actually, there is things to understand in that, definitely, but it's out of the scope of of understanding of a graduate student actually, you know. So I'll just keep myself limited that for an external observer, the amount of rotation occurring in the mandible amounts to just 4 degrees. And that's a direct pickup line from one of the textbooks. Although the total amount of rotation occurs approximately 15 degrees, but due to surface remodeling of the mandible in accordance with the maxilla, the amount of rotation which is observable to an external observer comes to fall around 2 to 4 degrees only. Just remember that. That's all. Nothing else has to be remembered. MFMC direction. What is MFMC? Acha, moment to force and moment to couple ratio. I'm going to come to that also. I will come back. I will come to that. Adhira Berkeley. Okay. So this is Kaman's growth curve. This has to be remembered. I know you already know this, but still, Scammon was a person who made distinctive observations of the 4 different tissue system, organ systems in the body. He talked about lymphoid system. He talked about central nervous system. He talked about it involuates, and it comes back to its original size of 100% by the time the child is approximately 18 to 20 years of age. That is number 1. Brain and head, that is central nervous system, it completes almost 90% growth by the time the child is 5 to 6 years of age, and only after completion of 90% of the growth, the rest of the remaining 10% of the growth, it happens until the time the child has reached 18 to 20 years of age. Am I audible, guys? Again, few people are saying that there is no sound. Please let me know. Am I audible? Maxilla follows neural or general curve. Maxilla follows, this is the maxillary curve, no? The maxilla is slightly ahead of the mandibular curve. So that can be explained by means of cephalocaudal gradient of growth also. Then reproductive system. The reproductive organs of the human body remains inactive until after the puberty has been reached. Only under the influence of sex hormones, growth hormones, there is a tremendous increase, there is an exponential increase in the growth of the reproductive organs, and they reach adulthood by the time the child has become 18 to 20 years of age. Okay, so that is important. Next is cephalocaudal gradient of growth. So cephalocaudal gradient of growth means it's a gradient of growth basically. Tiebacks, yes, I'm going to come to tiebacks. I have that in this slide, in this presentation. Just wait a bit, I'm going to come to that. So, cephalocaudal gradient of growth, there is a particular percentage of contribution of the head and the rest of the body. You see, when the child is a fetus within the intrauterine life, the head constitutes around 50% of the entire length of the body. It reduces to 35%. At the time when the child is born, the size of the head is almost 25% of the entire length of the body. That is almost 1/4 the height of the entire body. Okay. Then it reduces further to 23%, 20%, 18%, and finally 12 to 13% in adulthood. But does that mean that the size of the head is reducing? Is it reducing? Tell me yourself, is it reducing? Tell me in the chat box. Is the size of the head reducing or something else is happening? Let me know in the chat box. I'm waiting for your answer. Come on, tell me in the chat box. So, what happens here? The size of the head is not reducing. Actually, it's the size of the lower body which is increasing. The size of the lower body is increasing. You see here. From 16%, it's jumping to 25, 35, 40, 45, 48, almost 50% by the time the child is an adult. So what does this imply? It means that the lower half of the body, below the abdomen, below the head, the lower part of the body is increasing. It's growing at a faster rate as compared to the upper part of the body. That means the structures which are away from the base of the skull, which are the structure which are away from the brain, they have a tendency to grow for a longer period of time as compared to the structures which are closer to the brain. The head comprises of the brain, the upper limbs are closer to the brain, the abdomen, the chest, torso, the abdomen, they are all closer to the brain, but the lower legs are the farthest away from the brain, right? So that's why the lower legs, they constitute almost 50% the entire length of the body. They grow at a rapid rate, they grow for a longer period of time. So that is what is called as cephalocaudal gradient of growth. Clear? Condyle shows endocondylar growth. Okay, Ayushi. Now, one more important concept I would like to mention is that the maxilla, the reason I have included this particular diagram for your understanding is that this is the base of the skull. And you know the base of the skull is made up of frontal bone, the ethmoid bone, the sphenoid bone, the petrous part of temporal bone, and the basioccipital part of the occipital bone, right? There are areas of primary cartilages in between at the junctions of those bones which are called synchondroses. They are primary growth cartilages. Primary cartilages, they are primary growth centers of the base of the skull. Yes or no? By virtue of the growth of these primary centers, the base of the skull grows in an upward and forward direction. Please listen to me very carefully. The base of the skull grows in an upward and forward direction. But the maxilla is articulated with so many bones in the skull. It is so heavily articulated with the rest of the facial skeleton, with the rest of the nasomaxillary complex, that it becomes very, very difficult for the orthodontist to bring the maxilla out of the nasomaxillary complex. Yes or no? It is a difficult maneuver to do. But by virtue of its own growth, there is sutural growth here. The posterior part of the maxilla undergoes bone deposition. Now, every action is equal and opposite reaction. The growth of the bone, the movement of the bone which occurs by virtue of its own growth, that's called primary displacement. Yes or no? At the same time, the maxilla, as I said, it is articulated with the base of the skull, and the base of the skull is growing in an upward and forward direction. So this procedure, this maneuver, this growth direction of the base of the skull, it pushes the maxilla out of the nasomaxillary complex in a downward and forward direction. So the direction of growth of the maxilla is downward and forward. So it gets secondarily translated into space by push from the base of the skull. So it undergoes both primary as well as secondary displacement. Is it clear, guys? Also, the shaded part of the bone which I am drawing here, the shaded part of the facial surface of the maxilla, this part undergoes bone resorption by a process known as surface remodeling. So in conclusion, what you can say, that the growth of the maxilla depends on its own growth. The growth of the maxilla depends on the growth of the base of the skull. The growth of the maxilla also depends on the surface remodeling. So there are three mechanisms which go hand in hand. So the growth of the maxilla is a product of all these three mechanisms occurring together, one after the other simultaneously. Is it clear, guys? Is it clear, guys? Now I am going to just enumerate the different theories of growth. In brief, as you said, genetic theory given by Brody, sutural theory given by Fisher, cartilaginous theory James Scott, functional matrix theory. Now this is one of the most important theories, and it is one of the most sought after theories in modern orthodontic practice. Okay, before before introduction of this theory, it was a general consensus that the growth of the soft tissues is always following the growth of the hard tissues. Means what they said, what the researchers said before this theory was introduced in the orthodontic literature. They said that first it's the growth of the bones which happens. Grown bones पहले grow करता है, followed by the growth of the soft tissues. This was the original concept. Okay, but Melvin Moss actually changed this concept. He actually reversed this concept. He found out by a series of experiments that it is actually the other way around. The genetic potential of growth is always and always present within the soft tissues. The hard tissues always follow the soft tissue. That means the growth of the hard tissues is always secondary, compensatory, and obligatory response, obligatory and functional response, to the growth of soft tissues. So all genetic growth potential is present within the soft tissues. That includes the neurovascular bundle, the muscles, the periosteum, the nervous system, the glands, the salivary glands, the tongue, the organ system, the brain, the nasomaxillary complex, the maxillary sinus, the eyeball, everything. Right? So that is the whole fundamental core concept of functional matrix theory. That it is the soft tissue which grow first. That is followed by growth of the hard tissues. We have got certain levels of organizations also. I'm not going into much detail. It's going to take up a lot of time otherwise. You can go back to the notes. You can go back to the recordings. The very first chapter in the recordings, chapter number 1, you can go to that chapter. You can read about that. You can watch that video. I've explained this particular theory. In fact, all the theories in good detail in that chapter. Then we have servo system theory. This is particularly useful for myofunctional appliances. Then epigenetic theory, that the growth is a factor, the growth of the nasomaxillary complex, the growth of the craniofacial complex is a product of interaction between the environmental and the genetic component. That is epigenetic theory. Then Enlow's-Weir principle and Enlow's counterpart principle. This is in accordance to the contemporary orthodontic concept of growth basically. So Enlow's-Weir principle says that the growth of the mandible occurs along the wide end of the ramus of the along the wide ends of the V, where we have bone deposition along the inner surface and bone resorption along the outer surface of the growing ends of the V. So this helps in lengthening of the mandible. This also helps in transverse growth of the mandible also. That is Enlow's-Weir principle of growth. Okay. Shall I move forward? So this section is about doubts from cephalometric analysis. First and foremost, we have Eastman correction in cephalometrics. So what is Eastman correction basically? I'm going to explain that. It's also called as Mills correction. So basically what happens in Steiner's analysis, we have got two parameters rather. First is SNA, second is SNB, and third is A and B angle. Right? SNA, what is SNA? Sella, Nasion, point A. That is angle between them. That is SNA angle. SNB is Sella, Nasion, point B. And A and B is it's a difference between SNA minus SNB. Clear? Now, the point Nasion is not consistent. The point nasion is not consistent within the craniofacial anatomy. In some patients, the nasion is anteriorly positioned. In some patients, it is posteriorly positioned. So if this central value nasion is not consistent, what will happen? If a patient who has got more anteriorly positioned nasion, what will happen? The actual SNA angle will be reduced. The actual SNB angle will be reduced. And इसका उल्टा करें तो, if the nasion is more posteriorly positioned, what will happen? The ANB angle, the SNA angle will be increased. The SNB angle will be also increased. Yes or no? So to counteract this problem, there was a requirement of development of width appraisal and Eastman correction. So what do we do in this? The ANB angle indicates a relationship between the maxilla and the mandible, but it can be misleading if the nasion point is displaced forward or backward. I just mentioned this. The Eastman correction attempts to normalize these values to better reflect the true skeletal discrepancy. So mathematically, how do we do that? If SNA angle is more than 81 degrees, that is a normal one, that is a norm, right? Given by Cecil Steiner in Steiner's analysis. The angle, the value of SNA is 81 degrees normally. If the angle is more than 81 degrees, you have to subtract 0.5 degree from ANB angle for every 1 degree over 81 degrees. Suppose that means if, let's for example, if the angle, if the ANB angle is suppose 84 degrees, for example, 84 degrees. Now 84 degrees means it is 3 degrees above normal. So you have to subtract 0.5 degree for every 1 degree increase of ANB angle. So we have to subtract 1.5 degrees. So that makes a total of 82.5 degrees. So this 1.5 degree correction is called Eastman correction. Similarly, if the SNA angle is less than 81 degrees, if the nasion is more anteriorly positioned, if the SNA angle becomes less than 81 degrees, you have to add 0.5 degree in ANB angle for every degree under 81 degrees. Let's say again, ANB angle is, let's say it is 76 degrees, for example, and the normal value is 81 degrees. So there is a differential of 5 degrees, right? So 5 degree, we have to add 2.5 degrees as the final value. So the final result will be 78.5 degree. So this value 82.5 and 78.5 are called the corrected value in accordance to the Eastman's correction. Is it clear, guys? Please let me know in the chat box. Is it clear? Shruti is asking me which treatment removes the cause of malocclusion. It is sphenectomy. It is sphenectomy. It's not supracrustal fibrotomy. It is sphenectomy. Okay. So this is the nasion point. This is the nasion. So this can move forward. This can also move backward. Now to correct this, to make it more consistent, we have developed two different parameters. First parameter is Eastman correction, I just talked about, and the second parameter is width appraisal. Clear? Okay, okay. Next is mandibular plane is cephalometric analysis. Is it condylion to Nathyon versus gonion to Nathyon? Now, mandibular plane, different analysis, different mandibular planes. Just remember that. We have Down's analysis, we have Steiner's analysis, we have Tweed's analysis. Okay. Now, I have prepared a particular mnemonic to remember which analysis uses which mandibular plane. Down's analysis. So D stands for down, D stands for, I'll write it down, one second. So this is gonion to menton. Now what is menton? That is the inferiormost point on the bony chin. So menton is the downmost point on the bony chin. Downmost. Actually, it's not a verb. I'm just writing for you to understand. So D for down, D for downmost. And that means the lowermost point, that is menton. So gonion to menton is for Downs analysis. Steiner is gonion to nathion. And Tweeds is tangent to the lower border. So again, T for tweed, T for tangent. So that's how you can remember. There will not be any confusion anymore after this. Okay? And condylient to nathion, there is nothing called mandibular plane. Condylient to nathion is called mandibular axis. It's not called mandibular plane. It's called mandibular axis, or it can also be called as effective mandibular length in McNamara analysis. But as I said, McNamara analysis is not in your syllabus, so I'm just keeping the discussion limited till here. I'm not going any further than this. All right. Width appraisal. I just talked about the reason why width appraisal was created in the first place. Okay. And what is width appraisal? You take a functional occlusal plane. You drop a perpendicular from point A to the functional occlusal plane and from point B to the functional occlusal plane. This is point B, this is point A. And this point is called AO, this point is called BO. In males, the point BO is ahead of AO by 1 millimeter. Ahead means it is in front, and mathematically it is expressed as minus 1 millimeter. Minus means anything to do with class 3. In females, what happens? In females, the BO is coincident with AO. So there is overlapping of the two. You can remember it that way. In males, the chin is more prominent than females. So the males will have a class 3 tendency more as compared to females. So in males, we have minus 1. In females, it is 0. Any deviation from the normal will result in malocclusion, which will conclude in whichever type of malocclusion is. Okay, guys? How many ossification centers in the mandible? Again, the mandible is made up of 2 halves. 1 ossification center for 1 half. So total of 2 ossification centers. Does extracting a supernumerary tooth risk damage the permanent tooth bud, or should it be removed immediately or retained as it is? Well, for this you have to go for a detailed 3D CBCT analysis, image analysis. You have to determine the proximity of the tooth to the surrounding structures, particularly the nasopalatine canal, right? That you have to understand, that you have to properly analyze. You have to look for the surrounding anatomical structures, make a way for it, reflect the flap, and then extract it. So that's why just a 2D imaging, a 2D IOPA, 2D OPG is not sufficient. I will recommend you to go for a 3D CBCT imaging before undertaking any extraction of a mesodense tooth. Right, Harshita? Important angles. Again, we have talked about important angles in the recorded lectures. So the clinical implications of those angles is important. Almost all the cephalometric values, all the cephalometric parameters, whatever we have studied. So the clinical implication, the clinical interpretation of those angles is also important. Okay. And of course the inference is also, as I just said. Brody's bite is scissors bite. Scissor bite is an understatement actually. Brody's bite happens. Scissor bite is for one tooth actually. And Brody's bite happens when an entire section of the mandible is contained within the maxilla. Okay, so that is called Brody's bite. Which Ceph analysis does not reveal severity of anteroposterior jaw dysplasia? Which Ceph analysis does not reveal severity of anteroposterior jaw dysplasia? Tweeds analysis. It is Tweeds analysis. Okay. Easiest tooth movement, it is extrusion. Easiest tooth movement is extrusion, and the most difficult one is intrusion. Okay, Umesh, Swati, active and passive tieback, I'm going to come to that. Just wait a bit, I'm going to come to that. I have figures in your in the slides, I'm going to explain that. Difference between straight pull versus high pull headgear, types of headgear, and mechanism of action of headgears. Okay. Now, before that, we have to understand the biomechanics of headgear, first of all. So, you already know what is the CR, center of resistance of the maxilla. You know, na? So, this blue dot here is called center of resistance of the maxilla. It is present along the zygomatico-maxillary what is it called? Key ridge area, basically. I'm going to explain stationary anchorage also, Preeti. Just wait a bit. I'm coming to that part also. So this, you already know, C-res of the maxilla, and anything to do with the C-res that defines the exact movement of a particular tooth or of the entire maxilla per se, particularly. So if the line of action is passing below the center of resistance of the maxilla and the center of resistance of the maxillary dentition, excuse me, you will have a clockwise rotation movement of both the maxilla and the maxillary dentition both. In the second case scenario, okay, this I am talking about cervical headgear. First of all. In the second case scenario, if the outer bow is above the series of the maxillary dentition and below the series of the maxilla, so we will have clockwise rotation of the maxilla but anti-clockwise rotation of the maxillary dentition. You know, any point of force application away from the series will generate a rotational tendency. That rotational tendency is called moment. Excuse me. That rotational tendency is called moment. So that moment is a vector quantity. It will always have a direction associated with it. It will have a magnitude plus direction. Magnitude can be whatever. It's a product of force into perpendicular distance, but direction, it depends on the line of force, whether it passes above the series or below the series of the maxilla or the maxillary dentition. So this is the force vector of a high pull headgear. You see here, this is a high pull headgear. Here, the tooth is going to rotate backwards, means it is going to tilt distally, and it is also going to intrude slightly. So we have intrusion in high pull headgear, plus we have distal tipping also. Okay. Now this is the force vectors in a high pull headgear. Again, we have the series of the maxilla here, series of the maxillary dentition here. Here, again, the line of force is passing below the series of both. So we will have clockwise movement of the maxilla, clockwise movement of the maxillary dentition. In the second case scenario, when the line of force is passing below the series of the maxilla and above the series of the maxillary dentition, again we will have clockwise rotation of the maxilla and anti-clockwise rotation of the mandibular dentition. So that's why the importance of understanding the biomechanical principles of headgear is important. Okay. This is about a straight pull headgear. It's a combination pull headgear, also called as straight pull, combination pull, or it's also known as interlandi headgear. It's also called as interlandi headgear. Okay, so here it is, the force vectors are a combination of high pull headgear plus cervical pull headgear. So we will have a controlled distal movement of the tooth. We will have a controlled bodily movement of the tooth. Bodily movement of the maxillary molar. So that is a fundamental principle, that is a fundamental difference between the biomechanics and the forces acting in a high pull headgear or a cervical pull headgear and a straight pull headgear. Okay guys, what else do I have here? Types of headgear, I told you we have high pull headgear, we have cervical pull headgear, we have got combination pull headgear, we have got J hook headgear also. Okay, and we have vertical pull headgear, we have anterior pull headgear also. Mechanism of action of headgears, I just explained that, how the line of force vectors and how they are done. Okay, indications. Now cervical pull headgear, it is going to cause extrusion of the molars, I told you. Extrusion. Now extrusion will work in our favor in case of deep bite cases. In cases of patients having horizontal growth pattern. Okay. Whereas a high pull headgear is going to cause intrusion of the molar. So intrusion of the molar will work in our favor in case of open bite condition. In case of vertical growth pattern of the patients. So in those cases, a high pull headgear will be an advantage. Okay. So these are the basic indications of the headgears. Okay, I have certain questions here. FR2 is not used for class 2 division 1 if overjet crosses 7 mm. Why? Please explain stationary anchorage. I am going to explain that also. Just wait a bit, Preeti. Explain pitch, roll and yaw. Again, it is it is explained in the live and recorded lectures, plus it's there in the notes section also. You can refer to that. Condylian poke on is the effective mandibular length. Yes, that is the effective mandibular length. Absolutely. Because beyond 7 mm, orthodontic treatment is not sufficient. We have to go for orthopedic plus orthodontic treatment by envelope of discrepancy. Yes, that can be a reason for your answer, Sudha. Berksberry has given the right answer to Sudha. So yes, that is correct. Okay. Next question. A very favorite question of you guys. Column angle. It is an increase or decrease in class 2 division 2 malocclusion. So what is column angle basically? Let me draw a diagram for you. So these are two central incisors having different orientation with each other. Okay. Now we have a long axis of the tooth. You know that that's the long axis of the tooth. Now that long axis of the tooth has two parts. One is coronal part, one is the radicular part. Okay. So this long axis of the tooth has got two parts, coronal part and the radicular part. This is the radicular part and this is the coronal part. Coronal means crown, radicular means root. Now, if you extrapolate this line, the angle formed between the long axis of the root and the long axis of the crown. So this angle theta is called column angle. Okay, before that the spelling of column angle is C-O-L-L-U-M. It is not C-O-L-U-M-N. That is called column angle. Okay, that is the inside angle. Okay, now in class 2 division 2, what happens? The maxillary incisors are retroclined. You know that. That's a clinical characteristic of class 2 division 2, right? Again, we have the radicular part and we have the coronal part of the long axis. Again, I'm going to extrapolate. Now you tell me, is theta greater or is gamma angle greater? You tell me yourself. The answer is right in front of you. Which angle is greater? Is it the theta or the gamma? Tell me, come on. So without any doubt, it is the gamma angle which is greater than the theta angle. Yes or no? So this clinical presentation is of class 2 division 2 malocclusion. And this clinical presentation is of class 2 division 1 malocclusion, or it is also in class 1 malocclusion also. So you have the answer right in front of you. The column angle is greater in class 2 division 2 as compared to class 2 division 1. Is it clear, guys? Okay. Now I have one more question in relation to this. Increase column angle as a deterrent to incisor correction by orthodontic treatment. Okay. Now I'm going to ask you a question. I want your answer yourself. I want you to answer me in the chat box. I'm not going to give the answer myself, okay? Now you tell me, is a column angle an anatomical variation or is it a pathological variation? Tell me yourself. How the long axis of the root and the long axis of the crown are oriented to each other, is it an anatomical variation or is it a pathological variation? Come on, tell me. Tell me. I'm waiting for your answer. Come on, tell me. Is it an anatomical variation or a pathological variation? Come on, let it be wrong, man. It's okay. Yes, Sudha is saying it is anatomical, Berkeley anatomical, Srishti anatomical, Adi Berkeley, okay, Aditi. Everyone is saying it's anatomical variation. Absolutely correct. Can you do anything about it? Can you do anything about it? Can you do anything about it? Yes or no? No, it cannot be both, Pooja Shri. It has to be one of the two. It cannot be both. My question is, can you do anything about it? We can't. Orthodontically, you cannot. That requires a lot of tooth grinding. That requires a lot and lot of damage of the tooth structure if you want to correct this column angle. Now you give me the answer. Can you correct a column angle by orthodontic treatment? Can you correct an increased column angle by orthodontic treatment? Can you do that or can you not do that? Just simple yes or no in the chat box. Can you correct a column angle? Can you correct an increased column angle by orthodontic treatment alone? Can you do that or yes or no? So yes, it cannot be corrected. Meghna, Sudha, Srishti, Indu, Priya. No, Srishti is saying yes. No, bache, it cannot be corrected by orthodontic treatment. You cannot correct. It's an anatomical variation. You cannot correct it. Now, coming back to the question. Increased column angle as a deterrent to incisor correction by orthodontic treatment? So yes, that is a deterrent. You cannot correct the column angle by orthodontic treatment. All you can do is correct the inclination of the tooth. You can do a fixed orthodontic treatment when you are treating a class 2 division 2 malocclusion case. You can simply bond the bracket on the facial surfaces of the teeth, start with a fixed orthodontic appliance, procline the upper tooth. That's all you can do. And achieve a proper overbite and overjet relationships, both in the anteroposterior and vertical plane of space, right? But you cannot correct the column angle by orthodontic treatment alone. It is not a pathological thing to consider. It is a physiological variation. Every person has got different anatomical morphology, variations in the anatomical morphology. Biology is a science of exceptions, and class 2 division 2 malocclusion is a very common feature in the Indian population. Even I had class 2 division 2. I have undergone orthodontic treatment when I was in third year BDS in my college. I had class 2 division 2. So you cannot correct column angle by means of orthodontic treatment. Just remember that. Deep bite correction more difficult or column angle? Anirban, you tell me yourself. I'm not going to answer this. You tell me the answer. Now, next question. Freeway spaces increase in class 2 division 2 or class 2 division 1? What is freeway space? That's the vertical separation between the premolars when the jaws are in anatomical rest position, are in physiological rest position. That's how you define freeway space, right? In the vertical plane of space, yes or no? It's a prosthodontic terminology. It's available in glossary of prosthodontic terms also, GPT, not chat GPT. It's glossary of prosthodontic terms, GPT. Okay. Now freeway space, I told you that's a vertical relation, vertical opening between the upper and lower posterior teeth, particularly in the premolar region. Now, class 2 division 2 malocclusion has got retrocline incisors, right? It has got deep bite. More or less, it has got cover bite. To bring the teeth into edge to edge occlusion, edge to edge relation, the mandible has to be kept forward. You try it out yourself. Those of you who have class 2 division 2 malocclusion, you can try it out yourself right now. Just try to bring the mandible edge to edge with the maxillary anteriors. And then you tell me what will happen. What do you see? You can even use a mirror if you want to. You can go in front of the mirror, do it yourself. I'm going to tell you. Now, once the mandible and maxilla are in edge-to-edge relationship with each other anteriorly, you will have increased freeway space. You will have too much of vertical separation between the premolar region. And that is your answer. That itself is your answer. When the mandible is in physiological rest position in class 2 division 2, because of excessive curve of P, particularly, this is the curve of P, right? You know what is curve of P? I hope you know that. I'm not going to repeat that. So because of excessive curve of P, this freeway space is increased in class 2 division 2. It is increased in class 2 division 2 malocclusion. Please remember that once and for all. I am tired. Actually I'm tired answering this question again and again and again and again in Telegram group. I'm really tired answering the same question again and again. So once and for all, I'm telling you, it is increased in class 2 division 2 malocclusion. Just remember that, guys. Okay? Okay. Anirban is saying, you know the best, Baki sir. What do I know the best? Deep bite correction is more difficult or column angle. But yeah, I just said column angle cannot be corrected by orthodontic treatment. You can correct the deep bite. Yes, you can correct the deep bite. And correction of vertical malocclusion is again a difficult maneuver in orthodontics. More so, it is even difficult to retain that vertical correction, particularly the open bite correction. It is going to relapse up to a certain extent, that's for sure. So, deep bite is correct. Okay? Deep bite can have teeth with normal column angle. Yeah, deep bite. Yeah, yes, of course. See, deep bite is skeletal, dentoalveolar, both, right? Deep bite is skeletal and dentoalveolar, both. So whenever you have a skeletal deep bite because of class 2 division 2, the column angle is always increased. But we have dentoalveolar deep bite also. We can have cases which have supraerupted upper anteriors or supraerupted lower anteriors. In those conditions, the column angle will be absolutely normal, because it has got nothing to do with the anatomical variation of the tooth, right? Anatomical variation of the morphology of the tooth. So yes, then it must not be as difficult as increased column angle correction. Intrusion of incisors can be considered if freeway space is adequate. No, sir. Intrusion of incisors is considered only when you analyze, when you analyze the mini aesthetic part of the of the smile. Macro aesthetic, mini aesthetics, micro aesthetics. I hope you know that. If you don't know that, I want you to go and read in the chapter on essential diagnostic aids. You will have the answer yourself. So the amount of intrusion which has to take place depends on the cervicoincisal display of the tooth. That Morley's ratio, what you see. If the Morley's ratio is more than 75%, we can consider intruding the anteriors. If it is less, we have to extrude the anteriors. So it's a subjective thing actually. Okay. It is important to learn values of annual discrepancy. Yes, it is important. Yes, it is important. Now I'm coming to the next section. Four system, one couple versus two couple system. control versus uncontrolled tipping, root torque, couple, anchorage, types of anchorage plus mechanism, and stationary anchorage. So first and the foremost, couple. What is a couple basically? It's not boyfriend girlfriend couple actually. We are talking about couple in biomechanics. So the definition of couple is two equal and opposite non-collinear forces is called a couple. So this is a force, this is a force. So F and F both are equal to each other, but they are acting in opposite direction, which is not passing through a common point of rotation. So it is not passing through this red dot. So this creates a rotational tendency of the tooth. So this rotational tendency is known as moment of couple. And this rotational tendency of the tooth is called a couple. Okay? Now, one of the most important topics of today's discussion, moment of couple to moment of force ratio. Okay. Then I have, yes, I think sir meant skeletal deep bite is more difficult. Yes, of course, skeletal deep bite is more difficult to correct. Absolutely. Deep bite is most difficult to correct, na sir? Yes, it is difficult to correct. Toughest malocclusion to manage, sir, with just ortho or ortho treatment combined, it is class 3 malocclusion. Skeletal class 3 malocclusion followed by vertical open bite and deep bite. Bodily movement is best done by moment. That's an incomplete question. I'm going to explain that very question right now. So please pay attention. What's the name? Big dreamy girl. What's your real name, bache? I don't know your real name. So please pay attention to this particular topic. I'm just explaining you. There's something called moment of couple to moment of force ratio. Now, you know, we have a tooth here. We have a tooth here, right? We have a bracket bonded to the tooth on the facial surface of the tooth. Okay. We have the center of resistance here. This is called C-res of the tooth. Now, center of resistance is embedded within the bone. Is it possible to pass any force through the center of resistance? Is it virtually possible? No, it is not possible, right? So whatever forces we are employing, we are administering to the tooth. So the entire story happens here in the bracket slot, right? Yes or no? So whatever forces are acting here at the bracket slot, that is at some perpendicular distance to the center of resistance. Let's call it D. For example, let's take this example as D equals to 10 millimeters. And the force which is administered, let's say it's 100 grams. For example. So we have talked about this earlier also. Any force acting on a tooth which is passing away from the center of resistance at some perpendicular distance generates a rotational tendency of the tooth. That rotational tendency is known as moment. That rotational tendency is called moment. Moment is what? Force into perpendicular distance. Force is 100 grams, distance is 10 millimeters. So the moment generated will be 1000 gram millimeter. Which direction? It's a vector quantity, remember. Magnitude plus direction both. So which direction? It will be clockwise direction. Okay. So this will be clockwise direction. That is called moment. And in more refined term, that is called moment of force. Because that's a moment generated by the force of 100 grams, no? So that is called moment of force, which is denoted by MF. F is subscript. So this is moment of force 100 gram millimeter clockwise. All right. All right. Yes or no? Is it clear till now? Is it clear till now? Now, this I am talking about. Listen to me very carefully again. This I am talking about when we have a round arch wire within the bracket slot, which has got a single point of contact. One point of contact. One POC, I'll write it down for you. It has got only one point of contact in a round wire. Now what happens the moment you change to a rectangular wire or a square wire? The moment you insert a rectangular arch wire in a twisted configuration, we have changed a single point contact into 2 points contact. See here. So 1 point of contact becomes 2 point of contact the moment you insert a rectangular wire within the bracket slot. Now again listen to me very carefully. I want your attention here, guys. So we have talked about moment. Sorry, we have talked about couple. Couple is non-collinear forces, equal and opposite forces, but they are non-collinear. So the same concept is applying here. We have got 2 point contact, two forces equal and opposite, but not passing through a common center of rotation. So that is going to create a couple. This phenomena, this is going to create a couple. This couple is going to be created in a anti-clockwise direction. Okay. It doesn't matter whatever force the wire is giving. Let's forget about the force, but the moment which is generated at the bracket slot will be anti-clockwise. So this is known as moment of couple, which is denoted by M subscript C. Is it clear till now? We have got moment of force here. This is moment of force. And we have MC, that is moment of couple, which is generated within the bracket slot. The moment you insert a rectangular arch wire instead of a round arch wire, we have got the same amount of force acting here. The force is again 100 grams. But the only difference which has happened is that from a round wire, we have changed to a rectangular wire having 2 point of contact, generating a couple within the bracket slot. Now what happens? Now what happens here? There are 4 possibilities. The first situation, we have to look at this ratio MC upon MF. This ratio is important. It is important. Why? Because it gives you an idea of the type of tooth movement occurring within the oral cavity, within the tooth, whether it is intrusion, extrusion, rotation, translation, torquing, whatever. So if this MC upon MF is 0, this is the first situation. MC upon MF matlab the ratio between, one more thing, the moment of couple is also known as counterbalancing moment. It's also known as counterbalancing moment. So this MC upon MF, if this ratio is 0, what will it mean? The counterbalancing moment is 0. That means we are talking about a round wire having a single point of contact. So this will lead to uncontrolled tipping. This will lead to uncontrolled tipping of the tooth. Second situation, if MC upon MF ratio is more than 0 but less than 1, what will happen? If it is more than 0, less than 1, matlab kya? More than 0, less than 1. Now for this we have the moment is 1000 gram millimeter clockwise. Now for this ratio to be more than 0, less than 1, the counterbalancing moment should be less than 1000 gram millimeter. It should be less than that, na? That's why MC upon MF will be more than 0, less than 1. So this will have controlled tipping as a product. Clear? Third situation, if MC upon MF ratio is equal to 1, means MC, the counterbalancing moment is 1000 gram millimeter but in a clockwise direction, and the moment of force MF also is in 1000 gram millimeter but in opposite direction. What will happen? The ratio will be 1. The both will cancel out each other. So this will lead to translation movement of the tooth or bodily movement of the tooth. And fourth situation, if MC upon MF ratio is more than 1, what will happen then? Means the counterbalancing moment is more than 1000 gram millimeter and the moment of force is 1000 gram millimeter. You know that. Let's say if it is 1200 gram millimeter, if the torque, if the moment generated within the bracket slot is more than 1000 gram millimeter, what will happen then? We will have torquing moment of the roots. So what I mean to say is that you have to exactly know what is the meaning of this particular parameter, moment of couple to moment of force ratio. So this ratio ranges between 0 to 1, as I said. The clinical implication is that this ratio gives an idea of the type of tooth movement expected in a clinical setting, and these are the values and what are the clinical movements possible by these values. You have it right in front of your screen. I want all of you to take a screenshot of this drawing. Please take a screenshot of this drawing. It is for your own good. Based on this very principle, I have a previous year question for you. The question was, the counteracting torque for bodily translation of the following tooth will be. It is talking about the counterbalancing moment. Now we have bodily translation. Here we already know for bodily movement MC upon MF ratio should be 1. For that we have to understand what is the moment first of all. So the force is 120. The distance is 10 millimeters. So the moment of force will be 120 grams into 10 millimeter. That is 1200 gram millimeter clockwise, right? That will be clockwise. That is moment of force. For bodily movement, you have to have exact same amount. So MC should also be 1200 gram millimeter, but anti-clockwise. It should be anti-clockwise. Only then we will have this ratio MC upon MF as 1, no? It will be 1200 upon 1200. That will be 1. Both will cancel out each other. Yes or no? So we will have 1200 gram millimeter anti-clockwise direction. If I twist this question, instead of bodily movement, I have controlled tipping of the root. This is the final position of the tooth. What will happen then? If I have controlled tipping of the root, what will happen? For controlled tipping, I know that MC upon MF should be less than 1 but more than 0. So it should be less than 1200 gram millimeter. For controlled tipping, it should be 1000 gram millimeter anti-clockwise. So that's how you should be able to understand the concept of MC upon MF. That's an important concept, guys. All right. So MF is always clockwise and MC is anti-clockwise. Yes, more or less. You can say that. Yes. Okay, okay, you can take a screenshot, Srishti. I think you couldn't take a screenshot that time. You can take a screenshot now. Done? You can take a screenshot of this and you can take a screenshot of this particular slide as well. I want you to take a screenshot of this, all of you, please. Done, guys? Shall I move forward? Now, types of tooth movement. We already know tipping movement, controlled tipping, uncontrolled tipping. You already know that. Controlled tipping means when the center of rotation is at the apex of the root, and uncontrolled tipping is it's present very near to the center of resistance of the tooth, where the root moves in one direction, the crown moves in other direction. Bodily movement, the entire tooth moves in a straight line. The center of rotation is at infinity. Intrusion, extrusion, the tooth is moving in an arc, in a circular arc-like manner. So the center of rotation is present outside the tooth for both intrusion and extrusion. Torquing, the root is moving in one direction, the crown is not moving at all. So the center of rotation is present at the incisal edge, or it can also be present within the bracket slot. You can say that. uprighting and rotation. There is no particular center of rotation for these two particular teeth. Okay, so here it is. Uncontrolled tipping, then we have controlled tipping. You see how the tooth has moved. Here the MC upon MF ratio is more than 0 but less than 1. Here it is 0. For bodily translation it is 1, and for torquing tooth movement the MC upon MF ratio is more than 1. So I hope the concept is clear now. Now, one couple versus two couple system. This was also a question which was asked many times. I have to draw a diagram now. These are the incisors. These are the brackets bonded on those incisors. Okay. And I have a utility arch starting from the molar going all the way to the opposite molar. Like this. Okay. Now, this is called a utility arch. That is specifically used for intrusion mechanics. Intrusion utility arch given by Ricketts. Alright. Now, I have inserted a sectional arch wire within the bracket slot here. From lateral incisor to lateral incisor, I have connected the entire 4 teeth with a single arch wire. I mean, with the sectional arch wire. And I have ligated the intrusion arch with the arch wire using a ligature tie in the midline. So this maneuver creates a single point of contact. There's a single point of contact. I'm going to intrude the 4 teeth by utilizing a single point of contact. So this means that the amount of forces and the amount of magnitude and direction of moments can be calculated by mathematical equations. They can be exactly calculated. They can be precisely known by complex mathematical equilibrium equations, right? So such type of a system is known as one couple system. It's known as one couple system, also called as statically determinate system. Clear? So that's a type of system in which the exact direction of moments and the exact magnitude of forces can be known with precision. Examples of one couple system could be cantilever spring. I have a diagram right next after this slide. Then we have sectional arch wire mechanics. Right? Example again. So a one couple system in which forces and magnitudes can be known precisely. So an example is a cantilever spring to bring about a canine tooth which is highly placed in the vestibule into normal occlusion. So that's an example of a one couple system. Now what happens? Again, I'm going to draw the same diagram. We have a bracket, 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 and we have the same intrusion utility arch coming from the molar. But the only difference I've done here is that in this configuration, I'm going to insert the utility arch within the bracket slots of each and every bracket. Okay. Instead of using a sectional wire separately, I have included a same wire within the bracket slot of the 4 brackets. So what has changed now? This has changed. We will have multiple points of contact. There are so many contacts here now. Yes or no? So instead of a single point of contact, we have multiple points of contact. Now this will render the system as statically indeterminate system, also called as two couple system. Statically indeterminate system. in which the forces and moments cannot be known with precision. Cannot be known with precision. Example, loop mechanics. Example, fixed orthodontic treatment. Fixed orthodontic treatment mechanics. So whenever we have multiple points of contact between the arch wire and the bracket slot, that constitutes, that renders the system as statically indeterminate system, also called as two couple system, right? It is created by tying a rectangular intrusion arch into the brackets of the incisors. When this is done, the precise magnitude of forces and couples cannot be known. So please remember the importance of these. Okay. Next is anchorage. Different types of anchorage: simple, stationary, reciprocal, intraoral, extraoral, multiple, cortical, muscular, absolute anchorage. So simple anchorage is generated by a removable appliance. Stationary anchorage. Now somebody was asking me about stationary anchorage. So stationary anchorage is when we have the molars. This is the premolar, canine, incisor, incisor. Okay. We have the molar tubes, brackets, one second, hold on. Am I audible, guys? Am I audible? Please write yes or no in the chat box. So what I was saying, so I have inserted a arch wire within the bracket slots right from the second molar to the second molar of the opposite side. Now I am going to retract the anteriors. I have created a force system that is going to retract the anteriors into the extraction space. Now stationary anchorage is when the retraction of the anteriors takes place, but there is a bodily movement of the tooth. There is a bodily movement of the tooth. If the same thing had been done using a removable appliance, we would have obtained a simple tipping movement of the tooth, right? But here we are obtaining a bodily movement of the tooth. That is stationary anchorage. Was a question sometime, I think last year. It was a controversial question. So you have to mark the anchorage unit cannot move in that particular question. Somebody asked me earlier. I don't know the name of that person. So that's for you. Okay. So that is about stationary anchorage. Okay. Next, wagon wheel effect, important appliances with images, rapid discussion of image-based MCQs, active versus tiebacks, important concepts of aligners in orthodontics. So wagon wheel effect. What is wagon wheel effect? Okay. Okay, before that, I'm going to talk about active tiebacks and passive ligatures. So this was a previous year question which was asked. You were supposed to identify the correct option for sliding mechanism used in orthodontics from the image. So we have to understand what is figure of 8 ligature or lace backs. What is lace back basically? So lace backs are nothing but ligature ties made up of 0.009 inch or 0.010 inch stainless steel wire, dead soft heat treated stainless steel wire. What do we do in this? We pass the wire below the bracket, below the tie wings of the bracket in a figure of 8 manner, and we tie it here around the mesiogingival tie wing of the canine. So this is a figure of 8 ligature, also called as lace back. What is the importance of this? It can maintain the extraction space. I mean, it doesn't allow the opening of the space. Also, it helps in distalization of the canines. Also, it is required for anteroposterior anchorage control. Forget about all these things. Just have to remember how a lace back looks like. It's just a simple figure of 8. Next is passive tiebacks. Now here you have to understand the difference. Here you are using the same ligature wire, but the ligature wire has started from the hook of the molar tube, and it is going above the arch wire, and it is being inserted and ligated below the brackets of the canine tooth. So this part is going above the arch wire, whereas in lace back it was entirely below the arch wire. That is another difference between the two. Okay, clear? So that is passive tiebacks. Then we have active tiebacks. It's of two types, type 1 and type 2. It's exactly same as that of passive tieback. The only difference is in active tieback we have a module here. This green colored is a active elastomeric module, which is present distally. It is inserted distally, and this elastomeric module, when it is stretched, it is used to retract the anteriors. That is type 1 active tieback. The type 2 active tieback is exactly the same. The only difference is that the module is present mesially. It is present mesially over the canine bracket, over the canine hook. That is the only difference. Again, the importance is the same. It is used to retract the anteriors. But clinically speaking, and out of my own experience, I always prefer type 1 active tieback over type 2 active tiebacks, because they are easier to put. They are easier to ligate. Okay? See, this is the module. This is the module. In type 1 active tieback, this is the module. And in type 2 active tieback, this is the module. It is present anteriorly. This is present posteriorly. Clear, guys? Now, there were certain instruments which were asked as previous year questions. So we have a reverse tweezer bracket holder. It is used to hold the bracket while you are bonding the brackets on the teeth. Then we have MBT gauge, also called as Daughtry's gauge. It has got certain graduations, which is used for vertical positioning of the brackets onto the teeth. Okay, in respect to the incisal and occlusal edges of the teeth. Okay. Then we have orthodontic band pusher. This is used to this part. This is serrated actually. It is like this. This part I'm talking about. This part of the instrument is serrated to have a proper frictional grip. It is used to push the band through the interproximal contacts of the molar teeth. Right? That is orthodontic band pusher. Then we have lingual arch plier. So it has got certain serrations here. You can see the serrations here in the beak. They can be used to give the bends in the heavy arch wire. Then we have Boone's gauge, very similar to Daughtry's gauge. We have Boone's gauge. The only difference is that here there is a graphite pencil lead. So this is a better instrument than Daughtry's gauge for more accurate positioning of the brackets onto the tooth surface. So that is an advantage of Boone's gauge over Daughtry's gauge. Okay. Then we have spot welding machine. So this is a very bulky instrument. So it uses extreme amount of heat and extreme amount of resistance. So whenever it has got this part, I'm talking about this part. So it has got a platform over which the band and the molar tube can be kept. It can be soldered together. So high intensity alternating current is passed through these copper electrodes, and because of extreme amount of resistance or impedance, you can say, in alternating current, that is called impedance. Because of excessive amount of impedance and excessive amount of heat generation, the part which are in contact with each other, they melt and then they join together. So that is the mechanism behind spot welding machine. Then we have pin and ligature cutter. So this is a pin and ligature cutter. So the cutting edge is made up of tungsten carbide. It is used for cutting the ligature wires in the clinical practice. Just have to, It is so sharp, it is so precise. You can simply direct the tip of this instrument where you want to cut the wire, cut the bracket, cut the wire. Simply do that and get over with it. Okay. Now somebody asked me about wagon wheel effect, watermelon seed effect. Okay. So wagon wheel effect, basically, you just have to remember this ratio 4:1, that is torque addition leads to mesial tip loss. So whenever you have a tendency of adding torque in the lower anterior region, lower anterior bracket, if you're adding the torque, now that torque is added, you can see it analogous to a wheel of a cart basically. That's why it's called wagon wheel effect. So what happens here? You're adding the torque here. That torque, addition of torque leads to, that addition of 4 degree of torque leads to reduction of 1 degree tip of the brackets. That is called wagon wheel effect. Just have to remember this, nothing more than that. Nothing else is going to be asked out of this. Right? Then Falguni Khandelwal is asking me watermelon seed effect. It is specific. I don't have the diagram right now. So it is specifically applicable in aligner mechanics basically. So what happens whenever we have a lingually placed or maybe out of the arch premolar tooth, for example. So because of the squeezing effect of the aligner, sometimes it happens that the tooth gets shifted away from the main dental arch. It is very similar to you are eating a watermelon and you simply squish it and the seed of that watermelon gets flying away. Very similar to that. That's why it's called watermelon seed effect. Okay. So that you can put it that way, the tooth which is out of the arch, it gets further out of the arch because of squeezing effects, because of excessive squeezing effects by aligner material, by the aligner sheets, which are pressing against the tooth, which are pressing against the adjacent two teeth of that particular tooth. Okay, so that is watermelon seed effect. And drawbridge, it's not drawbridge, it is drawbridge. It is drawbridge, D-R-A-W, bridge. So what is drawbridge effect basically? If you have seen London Bridge, so that bridge is like this. It has got a mechanism of opening the central section of the bridge, so that will allow the ships to pass through it. Very similar to that. In orthodontics, whenever we have an open bite situation, we have no vertical overlap between the upper and lower anteriors. So this is the situation in vertical open bite conditions. The teeth are proclined, the brackets are bonded onto the teeth, but there is no vertical overlap between the teeth, right? So you are giving retraction force on both the teeth. So what is going to happen? Retraction will be there, but some amount of tipping will also be there. So this tipping, so the tooth comes to lie like this. Retraction plus tipping, both. So you will have a proper vertical overlap. So the teeth are going to fall back. Very similar to the central portion of this London Bridge. That's why it is called drawbridge effect. I just told you, na, it is drawbridge effect. J Nisham, it is called drawbridge. It is not drop bridge, it is drawbridge. Okay. Now, biomechanics of clear aligners, highly predictable movements are space closure, 2 to 4 mm of buccal or label expansion, incisor rotation correction, lower incisor extractions, deep overbite correction, and crossbite correction, which are non-skeletal in origin. Moderately predictable are root torquing, distalizing posterior teeth up to 3 to 4 millimeters, which they can be also used in periodontally compromised patients, mature teenagers, closure of mild open bite with retraction of incisors, and closure of moderate open bite with extraction cases. These are moderately predictable. And less predictable treatments are severe rotations of the teeth, extrusion with no retraction. Again, this was a previous year question asked last year. Question was, which of the following tooth movement is least predictable by aligner mechanics? The correct answer is extrusion. The reason? This is the tooth. and the aligners are well above the occlusal aspect of the tooth also. So where is the space? Space कहाँ है erupt होने के लिए? So that's why extrusion cannot take place by aligner treatment alone. If in certain cases, if we do want extrusion of the teeth to take place, we have to give something called as eruption compensation within the aligner. We have to give something called as eruption compensation. So this compensation is what will allow the eruption of the incisors to take place, which is otherwise not possible. Okay? That's why extrusion with no retraction, extrusion is one of the most difficult and most less predictable movements to take place by aligner treatment. Other less predictable movements are mesial movement of posterior teeth, short clinical crowns, people having short clinical crowns, and less mature teenagers. So aligner treatment are not very successful in such conditions. Difficult to treat malocclusions, crowding spacing more than 5 mm, skeletal problems, CRC or discrepancies, severely rotated teeth by more than 20 degrees, open bite anterior and posterior, and difficult to treat malocclusions. Again, we have extrusion, we have severely tipped teeth more than 45 degrees, teeth with short clinical crowns, multiple missing teeth arches, and closure of bicuspid extraction spaces. These are the difficult to treat malocclusions. So this was about aligners in brief, very, very brief. Okay. Now we are talking about retention. Okay. Now this table, self-retentive, we have cross-bite. Again, this was a previous year question, last year only. Question was, which of the following malocclusion correction does not require any retention? The answer will be cross-bite. It is self-retaining. Short-term retention will be required in corrections achieved after serial extractions, highly placed canines, incisor retraction, or correction of blocked out teeth. Medium-term retention or moderate retention for class 1 non-extraction, class 1 and class 2 extraction cases, corrected deep overbite, corrected class 2 division 2, and permanent or semi-permanent retention expansion cases, particularly in the mandibular arch, generalized spacing cases, severe rotation, severe labiolingual malposition of the teeth, midline diastema. This requires permanent retention, cleft palate cases, and adult patient with periodontal compromise. Okay, so this is an important table. So if you can remember, it will be good on your part. Okay, rotation is most difficult. In case of aligners you're talking about, no, extrusion is most difficult, followed by rotation. Rotation, you can have G8 optimized attachments, but extrusion is really difficult to achieve by means of aligner treatment only. Okay, now next is indices. The most important indices is IOTN. Only that is important. I have not seen any other question from any other index till now. Okay, both the aesthetic component and the dental health component, both are important. The difference between activator and bionator, I'm going to come back to that. Forces by expansion appliances that can range between 10 to 20 pounds, and 1 kg equals to 2.2 pounds. You can do the mathematical calculation yourself. Okay, so 1 kg equals to 2.2 pounds. It is expressed as LB. Then important features of twin block appliance. Again, I have the diagram. CVMI stages, I have a diagram. Biology of tooth movement, key mediators, phases, diagram. Space maintainers and space regainers, the answer is right in front of you. Space maintainers are used for maintaining the spaces created by premature exfoliation of deciduous teeth, whereas space regainers are type of appliances which are used to gain the space by doing some active movement of the tooth. Okay, then crossbite types and management basics. Crossbite types, we have skeletal crossbite, we have dental crossbite, single tooth crossbite, whole arch crossbite. And management depends. If we have to correct the single tooth crossbite, we can give an inclined plane, we can give we can give inclined plane, or we can give a Catalan's appliance. We can even go for the ice cream spatula also. Then we can go for a double cantilever spring, Z spring. We can give jack screw plans, we can give coffin spring, then we can give W arch plans, quad helix, Hyrex plans. It all depends on the type of tooth movement, the type of expansion which you require. Okay. Open bite and deep bite, I think we have already discussed in the previous part of this discussion. And ugly duckling stage, yes, it is seen in second transitional stage. It is seen in second transitional stage according to the standard textbooks of orthodontics. It is seen in second transitional stage. Please explain IoT and index. Bache, please, you have to go and refer to the note section and also the chapter on classification of malocclusion. I've explained about IoT in detail in those chapters. So this is the image of an activator, and this is the image of a bionator. So what is a bionator? It's a skeletonized activator. It's a cutout form of the activator. So the activator had a disadvantage that it was very bulky in nature. The patient was not very comfortable wearing that. And bionator, it is less bulkier. So the compliance from the patient side improves significantly. Okay, so that is how you differentiate between activator and bionator. This is a twin block. Twin block, as the name suggests, it consists of two acrylic blocks held together at certain angle, that is the angle at 70 degree from the occlusal plane. So the upper and lower occlusal blocks are inclined at 70 degree angle. The bite is taken, and a construction bite is taken actually by means of modeling wax. The casts are articulated, they are mounted, and this appliance is fabricated on that in that constructed bite position. And the primary mechanism of action of this appliance is to keep the mandible in a forward position, and rest is history. You keep the mandible in a forward position. There is condyle glenoid fossa remodeling around the TMJ area by according to the theory given by John Vodoris, that is called growth relativity theory. We have talked about this earlier. We have talked about this theory, no? In the chapter on myofunctional appliances. It was given by John Vodoris in the year 2000. It came into existence in the year 2000. This is the most accepted theory of mechanism of action of myofunctional appliances in general. Okay, so these are the features of twin block appliance. Again, it has got a delta clasp, which is a modified form of Adams clasp, and the advantage of delta clasp is that it is fatigue resistant. It is fatigue resistant. So the longevity of this particular appliance is more as compared to the Adams clasp. Then we have CVMI index, CVMI stages. So it depends on the morphology of the body of the vertebra. So Hassel and Farman, there were two people, Hassel and Farman. They actually divided those different stages and they named the different stages: initiation, acceleration, transition, deceleration, maturation, and finally completion. You can see it for yourself. The body of the vertebra, it was more like a wedge shaped in the initiation stage. It becomes slightly lesser wedge shaped in acceleration, followed by transition. You see here, it has become horizontally rectangular, and the inferior border of the body of the vertebra has become slightly concave. Right? Then in deceleration, again, it has become squarish, and the inferior border of the vertebra has become even more accentuated. This is slightly squarish. Then maturation, again, we have deepening of the inferior border of the vertebra. Concavity is increasing day by day, year after year. And finally completion, you can see the inferior border has significant concavity and the body of the vertebra is vertically rectangular. Whereas in transition, it was horizontally rectangular. You see here. It was horizontally rectangular. That is the difference, and that is how you want to exactly know for sure in a lateral program if such a case is presented to you as an image based question. Okay, you have to look at the inferior border of the body of the vertebra, and that's what makes it different from the rest of the stages. Now next doubt was the mediators. Yeah, this was the important factors involved in tooth movement. Just I'm enumerating the names. Extracellular signal related kinases. We have interleukin 1, leukotrienes, macrophage colony stimulating factors, matrix metalloproteinases, osteoprotein, prostaglandin E2. This is called the primary messenger. Just remember that. Then we have rank L, rank X, and tissue inhibitors of matrix metalloproteinases. So what is rank basically? So this is a ligand which is expressed by osteoblasts and T cells on the surface. Now this rank has an affinity to connect with two molecules, with rank or OPG. OPG is osteoprotein. It stands for osteoprotein. It doesn't stand for orthopantomogram. So that's a chemical which has an affinity to bond with rank L. Now, which molecule wins? It depends on the relative concentration between the two. If rank is present more in number as compared to OPG, so I'll write down the equation for you. So rank L plus rank will lead to osteoclasts, will lead to more number of osteoclasts. And if rank L plus OPG, it leads to lesser number of osteoclasts. It leads to programmed cell death of osteoclasts and relatively more number of osteoblasts. It doesn't affect the osteoblasts per se, but relatively it reduces the number of osteoclasts. So the relative number of osteoblasts is going to increase. So you are going to observe bone deposition in this case. And in the first case, you are going to observe bone resorption. So, this phenomena follows the principle of competitive inhibition. Competitive inhibition. There's a competition going on between rank and OPG. Which molecule is going to attract to rank L? There's always a competition going on between them. So that's why it is called competitive inhibition. It's the same mechanism what you must have studied in pharmacological pharmacodynamics chapter, Now the phases of tooth movement. So they can be divided into initial phase, where we have initial movement of the tooth within the pedial space. Then we have lag period. Now lag period can range up to 2 to 3 weeks. Here the machinery, the entire cellular structure and cellular machinery of bone deposition, bone remodeling is actually the body is preparing to start moving the tooth within the bone, right? So that's why it is called lag period. And once that happens, it is called post lag period, also called as exponential phase, also called as log phase. So here, here the tooth movement occurs in a straight line manner. So these are the different phases of orthodontic tooth movement. I think this was also one of the doubts, right? So finally, last 1 month orthodontics revision strategy. So you have to, as I have been always telling to my students time and again, you have to identify your weak points. You have to, it's only you can do that for yourself. You have to identify your weak points, make a note of them, sit down with a pen and paper, sit down with a textbook, whichever textbook you have followed. It could be Balaji, it could be Kharbanda, it could be Gurkirat Singh, whichever textbook you have followed. Just open the contents wala page and analyze for yourself that this chapter I'm good at, this chapter I'm not good at. Just make a note of it and you will know exactly where you are standing. Okay, once you have done that, you will know exactly what you need to do, which topics you need to read more, which topics are are on your fingertips. You will have an idea of that yourself only. Okay, so that is the last 1 month orthodontics subject revision strategy I would recommend for you. Just take some time, and whenever you are done with that, just open up the relevant MCQs. Just check whether you are able to solve those MCQs of those topics which you have read in the next 30-35 days from now onwards. All right. Most important topics, I've already talked about them. The growth and development, the topics we have already discussed, the Scammons growth curve, the cyclical rate of growth, the displacement of the maxilla particularly. So all those topics are important from growth and development. Functional matrix theory, very, very important. Okay. Then next chapter is, okay, I'll write it down for you. Growth and development. Next is functional development. Functional development, particularly the buccinator mechanism, the speech development. All these topics are important. Then we have classification and etiology of malocclusion. Very important again, particularly the Ackermann profit system of classification. That is important, right? Then next we have biology of tooth movement, biomechanics of tooth movement, very, very important. Then we have diagnostic aids. Then we have cephalometrics, again very important chapter. Don't make this mistake of omitting this particular chapter. You will regret it later, I'm telling you. Cephalometrics, interpretation of the angles, all those different angles. I've talked about the mandibular plane. How can you differentiate between Steiner, Downs and Tweeds analysis based on the mandibular plane? Okay. Then we have methods of space scaling. Now this chapter, methods of space scaling, this chapter is important from image based questions point of view. I've seen n number of questions as image being asked out of this particular chapter. So please make a note. This chapter is very important from image based questions. Okay. Then we have materials used in orthodontics. Again, you cannot afford to miss out on this chapter. Okay. Then we have myofunctional appliances. Then we have surgical orthodontics. So these chapters are important, which should not be omitted at any cost. Please explain Z point and saddle angle. Okay. So Z point is the geometrical center of the ramus of the mandible. So this is the ramus of the mandible. This is how it is with condyle. This is the ramus of the mandible. So I have just roughly drawn the diagram. So you have to mark 4 points: R1, R2, R3 and R4. This is R1, R2, R3 and R4. Make a rectangle and just draw the diagonal of the rectangle. The center point is called the Z point, given by Ricketts. Okay, Falguni, that's for you, right? And saddle angle is the angle between nasion, sella and articula. So this angle is called saddle angle. What is the clinical interpretation of saddle angle? The normal value is 123 plus minus 5 degree. If the value is more, it means the glenoid fossa is more posteriorly located. So patient has skeletal class 2 problem. If it is less than 123 degrees, that means the condyle glenoid fossa complex is more anteriorly positioned and the patient has a class 3 tendency. That is a clinical interpretation of that. Alright. What is the most predictable movement with aligner? Tipping movement. Simple movement, tipping tooth movement. Post lag is 48 hours. No, post lag occurs after 2 to 3 weeks. After 21 days it happens. Okay. So that's all for this session. Two quotes I have for you. Consistency beats intensity. Every single day you show up, you're already ahead of thousands who didn't. Just think about it. Consistency is very, very important. If you are, just take baby steps one after the other, just small, small, small baby steps, and you are through the finish line. That's all about consistency. And the last, which I have made up myself, the rank you dream of is hidden inside the pages you feel like skipping today. So that's why I said, don't make the mistake of omitting the chapters which I just mentioned. Okay, so the rank you dream of is hidden inside the pages you feel like skipping today. Okay, that's all for now. I hope you enjoyed the session. It was a long session, it's more than 2 hours. Okay, so that's all for now. Thank you so much, guys. Thank you for being with me till the it's already 10 minutes past 10 o'clock. So thank you so much, everyone. Okay, I have a question, sir. I meant there was a question. How long does post-lag period last? For answer was 2 days, 48 hours. Wanted to confirm. Thank you so much. Okay. So is it same as the art? No, no, no. Articular angle is different. Articular angle is sella articular to gonion. Sella articular and gonion. So this angle is called articular angle. Both are different. Okay, Falguni? All right. Thank you so much, guys. Thank you so much, everyone. Good night. Shabba khair. And I wish you all the very best for the upcoming exam. Just take care of yourself. Take proper sleep. Take proper diet. An active mind lives in an active body. You know that. Needless to say about it, right? So thank you so much. Thank you so much. Good night. Good night, all of you. Take care. Shabba khair. See you.